It's my pleasure today to introduce Deborah Whitley. Deborah and I go way back. When I first went to the hospital in Wellington, and John Bott said, you probably can't keep that one open. And Deborah was our consulting accountant, and it's still open. It's still successful. So Deborah's been a great friend, a personal friend, and a great friend to rural health. She's helped in a lot of special efforts, a lot of things that are outside the scope of what you'd normally expect an accountant to do. But without further ado, let me turn it over to Deborah. Great to be here with you.
Thanks, Mike. I'm going to share my screen with all of you real quickly so that you can see my slides. We'll move pretty quickly off my picture because that's 2 times on the screen is a little much, I think. Let's see if I can. So first of all, I want to thank everybody for being on the call today. I really I can't really see all the names and faces of who's on, but I truly appreciate you taking time to listen. So, and Kelly, I want to take a minute and thank you and Mike Easley for letting me talk today. They asked me to talk today about Medicare Advantage plans and things that we've learned in the rural markets. I've gotten to know Kelly a lot more through trips to Washington, D.C., and I feel like I think he saw my passion about Medicare Advantage plans in Washington, D.C. So our goals today, number one, is talk about the true implications and impact to the rural markets. We're going to talk about Medicare Advantage plans, and we're going to talk about them from quite a few angles. But most people think that Medicare Part C or the Medicare Advantage plans are new, and the impact that, turns out they're really not, because they've been around for a very long time. And so I want to spend just a few minutes talking about the history and the evolution of those plans so that you can get an idea of what's new is new to us. These plans have been around a long time. From the very beginning, these plans were introduced for the intentions of 2 things, reducing cost or reducing Medicare spending, and 2, to provide Medicare beneficiaries choices. So if you really think about why they're here today, those are some of the same goals that were intended years ago. The big question of why I think we're here today and why Kelly asked me to talk is, why is this suddenly a problem for rural hospitals? And that's, I think, what we're going to try to pull together by the end of the 45 minutes that we have to be able to answer that question. What's new and why is this suddenly a problem? So I talk a lot about healthcare and healthcare finance charges. But those finance charges really affect urban and rural, small and large hospitals. But the healthcare challenge itself for financial purposes is really different than any other industry. What other industry is willing to accept 20, 30, 40% of the bill and kind of be happy about it? So the part of the financial challenge in healthcare stems from healthcare being so highly regulated by the government. And I kind of have, that's the only topic on this slide that I really want to talk about at this point is so many hospitals have greater than 50% Medicare and Medicaid volume from their patients. So the government is regulates Medicare and Medicaid, and they have the authority to change those payment rates every year. And they have the authority to change those payment rates retroactively. And so honestly, they exercise those rights and many times put hospitals in situations for overpayments from previous years and recoupments from some of those early years. And so it's really hard at times for hospitals to work on their budgets, not knowing exactly what they're going to have to pay back from a previous year. So if I really could take a minute and just say, we need to put a subtitle underneath highly regulated by government, by the end of this conversation, we'll probably want to add Medicare Advantage plans to it, because it's added an altogether new finance challenge as we go along. So taking a minute, talking about the history of the private plans, Medicare Part C plans really go all the way back to the late 1960s, early 1970s, and then through the 1970s, to a time when Medicare beneficiaries first had options under HMO plans through demonstration programs. So what we think we're dealing with today is new. This really goes back to the 1970s. Then under the Tax Equity and Fiscal Responsibility Act, or TEFRA, there were again more HMO models that were developed and tested through the 1980s and 1990s. So we had 30 years, the 70s, the 80s, and the 90s of some of these private plans under Medicare. And I was real surprised that it went back that far. Then starting in 1997, the Balanced Budget Act came along, and that really scrapped all the previous plans and reduced payments to all of the plans. And for those of you on the call, I'll kind of tell my age here. I specifically remember when the 1997 Balanced Budget Act came out. I specifically remember thinking, I don't think rural hospitals are going to be open in 10 years. I think that was such a devastation back then. But here we all are, and we're still talking about it all. Consequently, then from 2003 to 2010, the Medicare Modernization Act actually had to come in and raise a lot of those plan rates to counter with the Balanced Budget Act cut. And that's the time period that the Part B drug benefit program came about. So then we kind of fast forward to 2010, where the Affordable Care Act brought a lot of the plan payments closer from the private plans to the traditional plans. And certainly reduced Medicare spending overall. But the Affordable Care Act brought a lot of initiatives to enhance quality of care overall. And as a result of the Affordable Care Act, we've seen a lot of growth in a lot of managed care plans. And it's eventually taken till about 2017, where we're starting to see the effect of the Affordable Care Act, where Medicare payment plans were equalized to traditional plans, and we're seeing much higher growth rates experienced in these plans. So let's start digging into what we see. This chart shows that the private plan payment rates were generally relatively paid at higher rates than traditional spending. Between 2001 and 2016, the private plans were actually getting paid on the average more than traditional plans. So from 2001 to 2016, we really didn't have a whole lot to complain about with regards to the private plans or Medicare Part C plans. But starting in 2017, as the Affordable Care Act finally got rolling along, that's when things actually changed, where private plans were not getting paid more than traditional plans. In fact, a lot of them are even getting paid less. So I think over the last 3 to 4 years is where we've actually seen more challenges with a lot of these Medicare private plan payments. As I've gotten to know Kelly Cheek, and as I've watched Mike Easley participate, I've also had the privilege of being in Washington, D.C. in every February. And I've had the privilege of actually going in legislative offices and talking with staff from a lot of the Texas congressmen. And I've learned a lot about the Advantage plans in the last couple of years. And some interesting facts about them are the program receives a lot of bipartisan support. So it's supported by both sides of the aisle, by Republicans and Democrats. And so because of that, I really don't think it's going away. I think these Advantage plans have some stability in them, and they're here to stay. So we're simply going to have to find a way to deal with it from a policy standpoint. Here's the brunt of what I've learned a lot about, and this is the reason I'm so passionate about it. The reason Washington likes these plans is because they're supposed to help control spending. And when we talk about Washington controlling spending, Washington's talking about paying hospitals less for services. So it's reducing hospitals' net patient service revenues. which is a really big challenge. And I think that's the reason that a lot of the rural hospitals today are having so much trouble with a lot of these Advantage plans, because 2017 is the breaking point. We're actually getting paid less than we had in the past. Statistics actually tell us, surprisingly enough, that seniors actually prefer the Medicare Advantage plans over some of the traditional plans. So let's take a look at that. Over the years, we've seen the penetration from the Medicare private plans go up and down, but since 2005, the penetration percentages just continue to rise. The projected numbers show us that through 2027, we'll continue to see growth in those private plans, even to the point of penetration greater than 40%. So there's another picture of why I think we have to realize these plans are here to stay. So I pulled I can pull market data to see these Medicare Advantage plans in their penetration rates based on counties or zip codes. And so I pulled a random urban county in Texas just to start looking at what these penetration rates are doing to us. In March of 2009, this urban county in Texas had a penetration rate of 18%. That grew to March of 2014 to 29%. And then that grew to March of 2019 to 37%. And when you look at the number of Part C enrollees, it goes from over 500,000 in 2019 to about 1 million in 2014, and then all the way up to 1.6 million in 2019. So we clearly see growth rates in urban counties all throughout Texas at similar rate increases. So when you kind of look at the list of what plans are out there, the list is pretty long. Generally, I see a lot of consistency between Humana and United plans out in the urban counties, but there are clearly other plans that are beginning to grow their presence throughout urban counties in Texas. And so you can see the list is pretty long. I pulled market data from a random rural county in Texas as well to find very similar growth rates. While the numbers are lower, there's similar growth rates. Random rural county in Texas that I see pretty consistently in different pockets around Texas. March of 2009, we see 9% penetration rates from Part C plans. That grew to 21% in 2014. And then that grew to 27% in March of 19. When you look at the numbers, while they're much smaller, the number of enrollees goes from 600 to 1,600 to 2,200 in this rural county. So clearly we see the Advantage plans growing in the rural markets as well. So in the rural markets and scattered around Texas, we find more than just Humana and United out in the rural markets. In this particular county, Care Improvement Plus had a pretty big presence, along with Sierra and Aetna that were growing a presence as well. So I think what it shows us is there is continued growth all across Texas. Different pockets of Texas have different percentages. So what we can see is the Medicare plans are actually out there, both in urban counties and rural counties. But let's just take a minute and talk about why do patients choose Medicare Advantage. So big picture, patients only deal with one insurance. There are no supplemental plans to choose from in the Advantage plans. Many offer lower copays. Probably a huge impact is vision, dental, or prescription drugs are sometimes included in the covered services of those plans. But I think there's a luring incentive. I think the marketing and I think the advertising for the Advantage plans is huge. I really learned a lot about the Advantage plans when I was home during the pandemic, working out of the office. My husband and I, over the lunchtime, he would want to watch Gunsmoke while we were eating a sandwich at lunch. I was amazed at the number of commercials for Medicare Advantage plans from retired football coaches and retired football players or comedians, pretty popular faces that continue to have advertisements every 12 to 14 minutes. There would be a 3-minute advertisement for Medicare Advantage plans. And so I don't spend a lot of time at home in the middle of the day, but when I did, found lots of advertisements for Advantage plans. So it comes across and it looks like a very attractive package. And it sounds like a really good option when you start telling Medicare patients that they do not have to spend money buying the supplemental plans. So I want to take a minute and talk a little bit about the pros and cons of each of the plans. And I guess what we really learn is you have to really look at it, what's the right thing for the individual patient based on the individual patient's needs. But some of the positive pros for traditional Medicare is it provides a lot of flexibility to the patient. They can pretty much see any doctor that they want, and no referral is needed to see a specialist. The coverage is really the same. I didn't find any restrictions on locations for traditional Medicare. In fact, if a patient lives in the panhandle of Texas and has a second home in South Texas or Colorado or California, there's still a lot of flexibility on the hospitals and doctors that the patients can see. Some of the the negatives are, because there is no cap on out-of-pocket spending on the 20% portion for the traditional Medicare patient, many of those beneficiaries choose to buy a supplemental insurance and then have monthly premiums. So there is out-of-pocket spending for traditional Medicare. And certainly we know that those don't include any of the extra benefits like vision and dental. They're pretty much exclusive to medical. So then we go to the positives or the negatives of the Advantage plans. And patients are told that they get the same services as Medicare Part A and Medicare Part B. We'll talk about that in a little bit to see if we all agree. But they also get coverage for prescription drugs, vision, dental, hearing aids, and perhaps even free or discounted gym discounts in their coverage for some of those plans. And many plans have $0 premiums. So along with $0 premiums and out-of-pocket costs being capped, and those capped amounts change from year to year and plan to plan, but there is a capped amount for the out-of-pocket cost. So I took that as a pro or a positive for the Advantage plans because it's very predictable on the patient side what should be paid. And the negatives for the Advantage plans are a little bit they're exactly contradictory to what the benefits are for the traditional plans, but there are restrictions for doctors and hospitals based on certain locations, and it's a requirement to get a referral for a specialist. So those are some negatives on the Advantage plan side, as well as changes are made to the plans annually that make it a little bit hard to keep track of. So the question you're asking, Deborah, is how are the hospitals affected? And so from the hospital's perspective, I hear repetitively and learned this from visiting with CEOs and CFOs from both PPS and critical access hospitals consistently. And certainly I've learned a lot of this from Mike Easley as well, that the Advantage plans really require much more manpower to process the claims than a traditional patient's plan. So I would tell you the hospitals are affected by higher cost to be able to get a claim paid. And my list here shows some of those examples. And I summed it up at the very top by additional manpower is required, but a lot of that stems from many of the Advantage plans have non-clinical administrative staff handling a lot of the claims. So there's a lack of medical or clinical knowledge with the people that are handling the claims on the Advantage side. To the point that a lot of times the Advantage plans require the physicians to step in to help confirm either the diagnosis or medical necessity rather than the medical staff. So now we've brought in a physician and we're for administrative time, and we're taking our physicians away from seeing patients to getting the Advantage plans claims approved rather than denied. I've learned that the Advantage plans actually put pretty strict time constraints on the hospitals for their response time, or they're denied. I had a doctor in the Panhandle tell me specifically, Deborah, I have to start putting administrative time, set aside administrative time, because often I'm given a date and a time where I'm supposed to call in to talk to the Advantage plan staff to get the diagnosis covered. Doctor specifically told me, Deborah, I was told by 4:30 on Thursday I needed to be able to call in to talk about Medicare medical necessity. And I called in at 3 o'clock. I was on hold for over an hour and a half. And at 4:30, I still had not talked to anybody. And the next day we were notified that the claim was denied. So truly we've got a lot of time from the physicians and medical record staff trying to meet criteria to get those claims approved. I had another administrator tell me that they have a problem with patient meeting certain criteria before approval of admission. They have a lot of patients that come through the emergency room that are not allowed to be admitted until they meet. The example that she gave me was had the patient was 0.2 degrees lower with their temperature that didn't meet admission criteria. So they had to send the patient home to get sicker before they could come back and admit them. And it was much harder to treat them at that time. So the hospitals are affected by and large with much higher costs to process the claim and then at times to even take care of the patient. So for a minute, let's just talk about patient care and how that's affected. From both the hospital and the patient's perspective, patient care is also a factor that's different between the two. This example is how it's going to relate to swing bed coverage. So a traditional patient qualifies for 100 days of swing bed care. So once a plan of care is set and goals are set, if the patient continues to progress towards the goals and actively participates in the plan of care, the patient continues to qualify for swing bed care. As opposed to a Medicare Advantage patient requires recertifies every 7 days to justify the swing bed stay. The plan of care and the goals are much more closely monitored. That results in two things: much shorter swing bed stays from denials and discharges that, number two, are sending patients home really before they're ready. So I think there's a consensus out there that patient care is dramatically affected as well. So I want to look at the much bigger picture of Medicare Advantage for the group. So logically, if Washington likes the program, then there's clearly a slowdown of spending that's occurring. And from what we saw earlier, really we're getting paid less starting in 2017 than we've been paid for greater than 20 years. So let's look at the flow of money. This is where the reality starts becoming harsh. On the flow of money for a traditional patient, Medicare actually pays the hospital directly. For an Advantage patient, Medicare pays the Medicare Advantage plan, and the Medicare Advantage plan then pays the hospital. So in order for all of this math to work, the Advantage plan wants some profit plus some administrative fees for actually their services to run the program. And the problem that we're starting to see, the harsh problem, is hospitals are getting less dollars actually allocated toward the payment for patient care. And so if we sum up what's happening since 2017, three things are occurring. We've had tremendous growth in the Advantage plans. The hospitals have to pay more cost to get the plan claim actually paid. And number three, the payment is less. So all of these things kind of are coming together under the Affordable Care Act. And those are the three impacts that are actually hurting the rural, what I'm going to tell you is the rural hospitals. We've got a bigger problem that's stemming from all of this. The patient actually loses the Medicare financial class and becomes a commercial patient for insurance purposes. So they actually lose their Medicare identity. The problem that stems from that is they're now identified as a commercial patient, and the hospital now has to negotiate payment terms directly with the insurance company. So for smaller hospitals or for rural hospitals, the negotiating power becomes minimal. And so we really have a take it or leave it mentality from the Medicare Advantage plans when it comes to the smaller rural hospitals. Taking it even another problem, another ultimate problem, as a result of the patient losing their Medicare identity, for those of you that are, for those hospitals that are critical access, or for those on the call that are familiar with critical access, when a critical access hospital actually becomes critical access, they have an agreement with CMS to get paid cost-based reimbursement for their traditional Medicare patients. When that patient loses his identity, you're not guaranteed cost-based reimbursement moving forward. Now, many of y'all are going to tell me, Deborah, we're getting cost-based reimbursement. Many of you critical access hospitals are going to say, Deborah, we're getting a cost-based reimbursement number. The problem is it's likely the letter from Medicare that you submitted from a previous period. So let's just talk about an inpatient routine day. You're probably getting paid a prior year rate. We're going to call it $2,500 in this particular case. There are so many different variables that we could run. I literally just took one hospital and converted some Medicare traditional days to Medicare Advantage days to look at this, to see the impact. But you might be getting paid $2,500 cost-based reimbursement from a prior period. And then when your cost report is actually calculated, the cost for that patient really probably might have been higher. In this example, it's $2,725. So really we're losing, for every Medicare Advantage day, we're losing, in this example, $225, but I can tell you that the numbers can grow fairly quickly. So we have lost revenues from our Medicare Advantage patients once they lost their identity as Medicare traditional. And then we could spend a lot more time talking about what is the cost of the dilution from the traditional patient for what you're getting paid on all of your other traditional Medicare routine days. And I would tell you that number is much higher than you might believe. There are hospitals that if they didn't allow a Medicare Advantage patient in their hospital, that the dilution is probably $700 to $1,000 additional lost reimbursement had we not had that patient at all once they lost their identity. For purposes of swing bed, kind of looking at numbers, a specific hospital scenario, for a swing bed day, I had a hospital that was getting paid $1,895 for their Advantage days in swing bed. and then the actual the cost report calculated $21.75. So there were lost revenues per Medicare Advantage swing bed day of $280. And again, in the example, there is a dilution, an inherent dilution of what the traditional patient costs are had we not had that Medicare Advantage day. So there are true lost revenues to the critical access hospitals for those Advantage days. So I used to worry a lot about critical access hospitals losing their benefit because of mileage and losing their designation. I would tell you my biggest fear for critical access hospitals today is the growth and penetration of the Medicare Advantage plans into the rural markets, and hospitals losing their traditional Medicare patients guarantee of cost-based reimbursement. That's going to be the biggest concern for critical access hospitals going forward. So I've got some more time, and I really want to kind of talk at why this is a big problem or why the problem exists. And so we talked about the Medicare Advantage plans, but when you really look at why they're here, it's because looking at this chart, you can see that the Medicare costs are projected to double over a 10-year period if we don't change our current patterns. And so those Medicare costs are growing for a couple of reasons. Number one, we have an aging population that's continuing to grow. The numbers of Medicare beneficiaries continues to grow in volume. But number two, we really do have increased costs to provide services. Doctors and nurses want to get paid more than they did in the past, and supplies and equipment and technology are continuing to grow in cost as well. So there's no question that Medicare costs continue to grow. But if other consumer prices grew similarly to healthcare, we would be paying $20 for a gallon of milk or a dozen eggs today, and we would be paying a projected cost of $30 or $40 for those similar dozen eggs or gallon of milk in the future if those industries grew at the projected rate of Medicare spending. And we know that's just not the case. So the growth in spending or the growth in healthcare costs have really been tolerated under the assumption that we are a healthier nation. But as we learn more and see the growth in chronic care conditions, we really are starting to learn that we're really not a healthier nation. So this pie chart shows that 79%, that big blue portion, 79% of Medicare spending is for people with 5 or more chronic care conditions. It's a perfect example of the 80-20 rule. 79 to 80% of our Medicare spending is on 20 to 25% of our Medicare population. So we really are going to need to learn a lot more in the future about chronic care management. Chronic care or chronic diseases are long-lasting conditions that can only be controlled, but they cannot be cured. And so, you know, I've got some examples on the slide: heart failure, diabetes, COPD, asthma, cancer. There's a long list. But those chronic care conditions are one of the reasons that our Medicare spending continues to grow exponentially. So I mentioned earlier that the Affordable Care Act brought about change. And I think the Affordable Care Act actually brought about the change that we're dealing with in 2017 with the Advantage Plan growth. But what the Affordable Care Act brought is not only changes in payments, it's not only changes in healthcare, but changes in the way we're getting paid. So it moves us, it's in the process of moving us from a pay for volume system to a pay for value concept for Medicare. And many of the other payers are starting to follow Medicare with the concept of value becoming the mechanism for payment. We've always had patient value as our mission, but going forward, that's going to be the mechanism for the payment. So we've historically been paid regardless of the outcome of the patient. The more services we provide, the more we get paid, and that's kind of been the ongoing growth of our Medicare spending. But in the future, as a result of the Affordable Care Act, I think the payment is going to be more dependent upon the outcome of the patient's services or health. So I think what we're finding, and through the Medicare Advantage plans, there's an overall attempt to control Medicare spending, and kind of reiterating that's the government's control over our hospitals' net patient service revenue. And I think we're going to find Medicare is going to reduce the amount of payments, and it's going to cause our Medicare net patient service revenue to go down. And in a lot of the rural hospitals, we're very dependent upon Medicare and Medicaid, but I think what we're finding is that's the intent, is for our patient service revenues to go down. So I have a summary just to kind of wrap all of this up. We can talk a lot about this summary, but Medicare Advantage plans, number one, are not new. But I think since 2017, they've become a part of the attempt to lower healthcare cost. And while I think all hospitals, regardless of size, large and small, urban and rural, while I think a lot of those are impacted, I really believe the rural hospitals' impact is going to be much harsher than the urban hospital impact. So at the beginning, we talked about how healthcare is unique in that we accept 20, 30, 40% of the fee as our payment. But the question is, can we afford to accept less than we currently do and survive going forward? Because the rural hospital's volume is already so low, and I worry there's just not enough margin to give up any more in payments. So kind of pulling all this together, as we've seen three things happening since 2017, we've seen tremendous growth in the Medicare Advantage plans, and I think that growth is just going to continue. We've seen the cost in the hospitals to process those claims grow, and we've seen payment cuts for the portion that's attributable to patient care go down in the Advantage plans. So three terrible things have come together all at one time. So we really have to start questioning, what are we going to do to protect the rural areas from the Advantage plan? Because I think the rural hospitals need to be exempt from some of these cuts because of the low volume and high fixed costs that they already incur. So what we have to really decide is, can rural hospitals cut costs in the same manner their net revenues are getting cut? Or are we going to find a way to exempt them? And these are a lot of the issues I think that everybody is talking about. But I think the Advantage plans really add to the concerns of Medicare spending being cut for the rural hospitals. And I think that's kind of a really big topic that needs a fair amount of attention going forward. Kelly, that's kind of all I have. I don't know if we want to take time for questions now or move on and save the questions for the end. I'll turn it back over to maybe Mike or Kelly.
Any questions? We can entertain those through chat. So Deborah, what are we going to do? It all looks pretty grim.
Well, I think, and Mike, you were with us in Washington, D.C. in February. I don't think that I saw a lot of reprieve coming from Washington, but I think we're going to have to fight harder. I think this is going to be, the more the growth in these plans are, the more detriment to the rural hospitals, and especially the critical access. And so I'm in fear of what this could do to us.
Well, one of the things that was interesting when we were there and we would talk to the aides and we said we weren't happy with Medicare Advantage to the person, they were surprised.
They did. They seemed very surprised, didn't they?
They did. So they don't.
I feel like that's why Kelly had me talk about this, because he heard a lot about it in February and knew that I was pretty passionate about this problem.
Eventually, all the rural health programs could be negotiated away. Here's something. Kelly, you have anything to add? No.
Are you there, Mike? I think there's a question from Dr. Phillips in the chat box, if you want to read it.
It says, let me see. Do you think if we learn through COVID how to build regional networks of hospitals that we might increase volume? What do you think, Deborah?
Well, I have a hard time understanding. I hope after COVID, we get back the volume that we once had. I'm quite concerned on the amount of volume that we're going to have in the rural hospitals as more of these patients start getting accustomed to going to the urban areas because of COVID. I don't know. I have great concerns about volume in the rural areas pre and post COVID. Mike, do you agree or disagree?
No, I agree. We've really seen a big drop off in volume that I'm not terribly optimistic is going to come back anytime soon. The people just aren't there. We had an article in the Austin paper recently with one of the emergency medicine physicians, and he was saying that the volume in the emergency departments at his hospital are down over 50%. And that's what, on the other hand, we hear the hospitals are being overwhelmed.
Hey, Mike, I think Dr. Phillips, again, made a comment. We might, Caleb, is there any way to unmute Dr. Phillips since we got a few minutes? He might have a few more comments if he's open to that from Dr. Phillips from Texas Tech.
Hi, y'all. Boy, did I enjoy that. Thank you very much. Yeah, we're hearing it out of both sides of people's mouths. Volume's down, and yet we're overwhelmed. And we've begun to have conversations with good people like John Henderson and TRHA about is there a way we could connect big referral centers? I'm going to use Lubbock as an example. UMC and Covenant during the COVID crisis have received a lot of patients out of a lot of parts of Texas because we had the capacity to expand our ICU floors, intensive care floors, and our actual ICUs. But in the meantime, that could not have been done if we didn't stop elective procedures. So General Med Surg, which is a revenue producer for a big hospital like that, was stalled, no revenue coming in, but yet you look at the counties within the hospitals within an hour's drive of us, and you see of the 1,116 total beds, you see 696 that are outside Lubbock County. So rural hospitals that could be driven volume during this time to allow more expansion. And of course, the devil's in the details, but how can you make that work? There's got to be a way, it seems to me, for us to think about, a concept that we're hearing the Texas Association of Family Physicians. We heard this in one of our previous seminars, talk about reinstituting regional care networks, primary care networks. Well, why couldn't that be expanded to think about how we relate hospitals regionally? We all have to have interlocum agreements to get JCHO accreditation, but what do they really mean? How can we make this work? Because volume can be driven into rural communities, especially in times like COVID. But and it's just a thought, and I'm just curious what other people who live in the real world think about it.
There have been some conversations. I was talking to John Henderson this morning, and they have been approached on a couple of initiatives at a fairly high level to talk about that kind of coordination to move some patients out into the rural hospitals that are underutilized.
I just think it's a great opportunity for us to, especially in places like West Texas, although it would probably work in any rural area, but if we could prove the concept and increase volume, I do think there's got to be some changes on the federal level, you know, to afford some of the stabilization of the market. And I don't want to put words in your mouth on that at all, Deborah. I'd really like to hear your thoughts about it, but I would think that there ought to be some structure to that is, because it's a resource. Either we stabilize our rural hospitals or we're going to go broke in the urban centers. That's all there is to it. You agree with that?
I agree with you wholeheartedly. I remember the same feeling back in 1997. Something's got to happen or these hospitals will close. And then, 5 years later, the Medicare Modernization Act came along and kind of offset. So something absolutely has to happen, without a doubt. Otherwise, they won't survive.
Well, let's continue the
Pennies on the
conversation.
dollar, really, if you think about it. It'd be penny wise to just spend a few pennies to stabilize the network and the overall scheme of what we spend on healthcare, especially if we went to an outcomes-based system. Just those thoughts.
Appreciate the thoughts.
Yep, thank you. Excellent.
Thank you.